Today we're doing a hip arthroscopy for a symptomatic labral tear in the right hip. And this is a lady who's had pain for over a year with some catching and some clicking, painful catching and clicking in her right hip. Her diagnosis was made. It's a very difficult diagnosis to make with standard imaging techniques. An X-ray doesn't show you this, and a plain MRI typically doesn't show you this. Most of the time, this is something that in order to see the labral tear, you have to get what's called an MR arthrogram, where the radiologist actually injects some gadolinium dye into the hip, into the joint, prior to doing the MRI. So it's a little bit more involved than just a knee or a shoulder or an elbow arthroscopy. Well, hip arthroscopy is somewhat some emerging technology that they really started probably doing 10, 15 years ago, but it's really been over about the past 5 to 8 years that the technology has really gotten better so that it's a lot more practical for more people. She'll have three 1 centimeter incisions. And typically speaking, you're able to do it through that. Sometimes there's two compartments to the hip. There's the central compartment, which is where we're working today. There's also the peripheral compartment of the hip, where some people that have impingement problems or sometimes loose bodies, we have to get into the peripheral compartment of the hip. So sometimes people would end up with as many as 5 or 6 small incisions. Typically speaking, we're able to do the vast majority of what we're going to do through 3 incisions, but sometimes up to 5 or 6, just depending on what the pathology is and whether we have to get into the peripheral compartment or whether we're just working in the central compartment of the hip. There's a lot of different indications for doing it. The most common pathology we see is a labral tear or a cartilage tear in the hip itself. There's also cases for what we call femoral acetabular impingement, which is a bony impingement where people will have hip pain. And it's thought that it may even be a little bit of a predecessor to an arthritic condition in the hip, and hopefully something that can be treated to either delay or prevent the progression of arthritis in the hip, and at least get people some pain relief and hopefully delay the need for some more aggressive surgery. That's an X-ray, that's a portable X-ray machine, so we can see where we're going, putting the first portal in. Once we've done that, once we're actually in the hip, the rest of the portals will be done using that and looking straight at it. This is establishing the posterior lateral portal, and the key here is you want to stay off of the articular cartilage, the joint surface, and you want to stay out of the labrum. You want to come just through the joint capsule and avoid those structures, because those are important structures for the stability and for the cushioning of the hip. Once we've gotten our portals in, then we're able to get some saline, some sterile saline coming in so that we get some water flowing into the hip, and that usually helps us with visualization as well. Now we're in the hip and we've gotten our portals established, which is most of the time is the hardest part of the case, really. If you've got good visualization, the rest of the case should be fairly straightforward. So here we're looking at a labral tear. Hers is just redundant, and it's this piece. See a probe, please. It's that piece right there that's getting pinched. That's what's getting pinched in her hip. So that's what we're going to need to trim back so that it's no longer able to get impinged. That is that's the flap that's getting pinched in her hip. Let's open a straight shaver, please. Straight shaver. So that's her pathology there. We'll take a picture of that so I've got something to show the patient. Again, I think I've got adequate mobilization of my joint capsule such that I'm going to be able to work. So this is just a little mechanical shaver. Has suction attached to it so that you can start cleaning that little tear up. We're just that's just a torn flap of cartilage that's getting pinched in the hip joint. And so we're just going to trim that down until we feel like it's no longer able to get impinged between the bones. There's usually not, people can fall and get a tear like this. Most of the time, it's just something that just happens. People just start developing pain, and it's kind of just attrition. Over time, the tissue just wears a little bit, and as it wears, you can develop some small tears within the cartilage, and as you develop those small tears, that tissue gets edematous or swollen, and when it gets swollen, it obviously gets bigger than it's supposed to be, and that's usually when people will start developing, when it gets big enough, they'll start developing problems where it can get pinched between the 2 bones that make up the hip joint. See how she's kind of getting that yellowish tissue? That's just, degenerative labral tissue. We're close to being finished with what we're going to have to do through this portal, and then we'll just switch back and switch our camera back through this portal that we're working through right now, and then we'll work from that anterior portal. This is working through the anterolateral portal right now. And again, you're just debriding back enough of the torn tissue so that it's no longer able to get pinched between the bones, because that's what's actually causing their pain. Some of these people will actually have locking symptoms of the hip or a painful snap. Other people just have pain with certain motions. Usually the pain's when people flex their hip, move it to the side, and positions like trying to cross their legs, that type of thing tends to hurt people. The satisfying thing about these cases, most of these people, if they've got the right pathology, meaning a cartilage tear or a loose body or something along those lines, they tend to get better fast, meaning usually within, this particular patient has been hurting for over a year, and I would anticipate her having some pretty significant pain relief within the next 2 to 3 weeks, sometimes even sooner than that. It's an outpatient procedure. People are usually on crutches for somewhere between 1 and 2 days, sometimes up to 1 and 2 weeks, but typically speaking, it's usually within a week. I would say the majority of my patients are off crutches. I do not routinely send these patients for postoperative physical therapy. I usually will see them back a week or two post-op. If they're having problems with stiffness or some things like that, then we'll send them with physical therapy, but I've found that the majority of these patients don't require any physical therapy afterwards, which again is fortunate for the patient. There's some other indications like loose bodies in the hip or sometimes even synovitis of the hip. Other people who've had a hip dislocation or some other type of a traumatic injury to the hip can have a torn ligament in the hip that actually pops in and out of the hip, and that's very successfully treated arthroscopically. Really here you can see where she had that big flap that was able to get pinched in the joint. It's gone, okay? And I've trimmed this back basically to what I would consider a normal area for the labrum. So where she had the tear, and like I mentioned earlier, where that can just get swollen and edematous, where it can get pinched in the hip, I've just trimmed that area back to where I feel like that's kind of the normal appearance to the acetabular labrum. And you've got a 70-degree scope, meaning your scope has a 70-degree curve at it, so you're really able to visualize, because of that angle, most of the hip. She fortunately really does not have anything as far as any significant arthritic changes or anything like that, and I really think her biggest problem was the labral tear, and I just don't see a whole lot more that we've got to do.